If you want to know what a typical hospital journey can look like before your loved one is going home with intensive care at home, stay tuned. I've got a case study for you today. My name is Patrick Hutzel from intensivecareathome.com, and I will showcase today what some hospital journeys can look like, because we're having many families reach out to us and wondering, what does a hospital journey look like before people can choose intensive care at home? Can we go home earlier? Should we go home later? I want to share a situation with you today, what it can look like, so that you have an idea what conditions can go home, what are your best options, and so forth. So I'm going to look at a hospital discharge summary today, and that can be a very typical hospital discharge summary for some of our clients. So stay tuned. So the context here is that the client has been in ICU since April last year, right? For me, the time of the recording of this video is March 2025. Client has been in ICU since April 2024. So we are talking about nearly 12 months now. Bear in mind, this is an email from January this year. So, I'm just coming to it now. But let's look at some of the history that's documented in the discharge summary, so you can have an understanding what some patients are dealing with. Whether you are a family watching this, whether you are a doctor or a nurse watching this, doesn't really matter, but you will get an idea. So I'm not mentioning any names, of course. 64-year-old female with multiple medical problems, including a stroke. The patient presented to the hospital on the 30th of April 2024 with concerns for possible seizures. Of note was that the patient had been hospitalized prior for a stroke, complicated by a need for a hemicraniotomy and evacuation of blood products. She also was started on hemodialysis during that stay. PICC tube was placed in tracheostomy as well, and she continues to be ventilated with a tracheostomy. She ended up in ICU due to the need for escalation in levels of care and for further evaluation and management. In ICU, internal medicine was consulted to provide recommendations on medical management, and also was asked to follow up with her. The patient had since been moved to a step-down ICU, but then transferred back again into ICU on the 2nd of June with hypotension. And patient was later found to have an intraventricular hemorrhage, thus stayed in ICU. So, medical issues, possible seizures and tremors. This is obviously of concern, and serial imaging without evidence of new or acute findings, rather laminar necrosis expected as per neurology. Neurology consultant following and notes overall, there has been concern, but patient has had 5 EEG studies, none of which have shown right hemisphere seizure activity. It is noted that the patient has tremors and lip movements which are not seizures, but rather due to cerebellar strokes. I will also go through the list of medications later, so you can see what medications the patient is on and whether it can be managed at home and so forth. The discharge summary continues. CVA, or stroke history, earlier in 2024. Ischemic MCA territory in context of atrial fibrillation history, shower emboli. A thrombectomy was done in early April 2024, which was complicated by hemorrhage and required hypertonic saline, and then hemicraniotomy on the 12th of April 2024. Will be a candidate for possible cranioplasty on or after in December. Patient noted recently to have small amounts of intraventricular hemorrhage, and thus was monitored in ICU until the 12th of June 2024. Following and repeat head imaging on the 13th of June showed likely new developing small frontal subdural hematoma. Repeat imaging again on the 15th of June and then on the 11th of August. No plans for a shunt nor bone flap surgery at this point. The family is asking if she can talk again to the neurosurgeon, and again, a consult has been placed. Spoke to the family and does not recommend any further intervention at this particular point in time. Next, chronic hypoxemic respiratory failure, noted during previous hospitalizations, trach placed, tracheostomy and ventilation placed on the 20th of April, 2024. Tracheostomy and ventilation is stable at the moment. Had been on the ventilator and has been unable to be weaned. Patient was removed from the ventilator. However, this was rescinded. Remains on and off the ventilator. Continue nebulizers to help some secretion management. Patient had recent issues with secretions, hypoxemia, and required supplemental oxygen, currently on heated, on humidified oxygen. Next issue is chronic dysphagia, noted in context of the above. High risk of aspiration as well. A PEG tube was placed. Patient was continued on tube feeds until she had vomited and residuals in the past. Continues to note have residuals. Thus, PEG placed to gravity drain. Since then converted to a patch tube and had been tolerating tube feeds, but this somehow became dislodged. And interventional radiology attempted multiple times to replace. A top-off placed on the 22nd of August to bridge the gap. The G portion, the PEG tube portion, was replaced on the 27th of August. And one of the doctors endoscopically placed a PEG and a patch tube on the 3rd of September, and now she's back on tube feeds. Adjusted Lantus dose most recently on 23rd of September due to hyperglycemia. What that means is the patient has been started on Lantus, which is insulin, due to high blood sugars. The discharge summary continues. Hypertension noted acutely in the afternoon on the 2nd of June. With blood pressure as low as into the 60s, uncertain what may have triggered this, though could have been aspiration with vomiting earlier in the day. Chest X-ray ordered with no acute changes. Blood cultures ordered. IV fluid bolus given, and then additional fluids ordered along with albumin per pulmonary and respiratory team. Also discussed with nephrology and agreed with current management. Blood pressure persistently remained low and required some inotropes and vasopressors, and that was discussed with family at length. Patient was then restarted on midodrine of IV inotropes and vasopressors, and then eventually midodrine was stopped again. So vasopressors and inotropes are medications that are given to increase blood pressure when blood pressure is low, and fluid boluses, for example, are not working. And midodrine can be managed at home. We have clients at home on midodrine, and this client can be managed at home as well on midodrine. The next section that I want to focus on is infections and fevers. Patient had lots of fevers while in ICU, and fevers have resolved on cefepime, which is an antibiotic, as there was a concern for sepsis. Zosine, there was a zosine course as well, which is an antibiotic because of increased secretions and hypoxemia. A 7-day course of augmentin was added as well for concerns of developing pneumonia versus aspiration pneumonia. Recurrent fevers noted, shows bilateral pulmonary opacity suspected to be atelectasis. Started on IV antibiotics as per ICU consultant. And then they got discontinued eventually. Now, the problem in ICUs versus a home care environment is often that there's a much higher risk for infections, whether that's because, ICUs are full of bacteria from other patients, and it's much more likely that the transmitters of these bacteria are doctors and nurses, despite all infection control and universal control practices. Whereas a home care environment is a much cleaner environment, and patients are much less likely to end up with an infection. The patient is also now in end-stage renal failure, and she needs 3 times a week hemodialysis, but that can be done either as an outpatient or can be done at home with our nurses. Next, the patient has a history of atrial fibrillation, and she is therefore on amiodarone as well as the digoxin, and it's unlikely to go away, and she will remain in chronic AF, atrial fibrillation. So, despite maximal efforts and lengthy ICU stay, the patient has not made any significant neurological recovery since the stroke and remains obtunded, but the family is adamant to wanting her home for whatever time she's got left. Now, let's also have a look at the list of medications. So she's on albuterol nebulizer, amiodarone, Ativan, compazine, depakine, Dorneb, heparin for deep vein thrombosis prophylaxis, hydralazine for hypertension or high blood pressure. She's on regular insulin. She's on Keppra. She's on midodrine, low pressure, Mylanta, saline nebulizers, omeprazole, Phenergan, Reglan, which is also known as metoclopramide, Tylenol, Vimpat, and Zofran. Also lacosamide and lorazepam as well. So, whilst this is a really complex patient that's been in ICU for nearly 10 months, it is time for this lady to go home. And she could have gone home much earlier if the patient and the family had known about us earlier, or the family had known about us earlier. But better late than never. Also, the ICU should have looked at options much earlier, because at the end of the day, it costs $5,000 to $6,000 per bed day to keep someone in ICU, and someone who stays there for a long time is also blocking a bed for someone that is in need of higher acuity intensive care or critical care. We've made it our specialty to get chronic and long-term ICU patients out of ICU with intensive care at home, and send the right teams in that environment, in the home care environment. Put together the right teams for the patient and the family, of course, so that patients and families can have quality of life, and in some instances, quality of end of life at home, instead of staying in ICU with chronic conditions like was the case with this lady. So I hope that gives you an overview of the level of complexity that we are sometimes dealing with, and ICUs are dealing with. And it's also a challenge for ICU to deal with those patients and map out the right next steps here. That is not easy either. But the good news is here is an option with intensive care at home. And like I said, ICU bed costs $5,000 to $6,000 per bed day. Intensive care at home is around 50% of that. So there's a win-win situation, not only from a quality of life perspective, there's also an economic argument by saving costs and freeing up an ICU bed, a much needed ICU bed, I should say. So with intensive care at home, we're currently sending our critical care nurses into the home 24 hours a day. That means we are providing a genuine alternative to a longer-term stay in intensive care for ventilation, tracheostomy, home BiPAP, home CPAP, ventilation without tracheostomy, tracheostomy without ventilation, home TPN, home IV potassium, home IV magnesium infusions, IV fluids, and IV antibiotics. We're also providing ventilation weaning at home, and we're also proficient in the use of cough assist devices. We're also providing central line management, peak line management, Hickman's line management, as well as port management at home. We're also providing nasogastric tube, PEG tube, nasogastric tube management at home, as well as palliative care services at home. We're also sending our critical care nurses into the home for emergency department bypass services. We have done so successfully as part of the Western Sydney Local Area Health District, their In Touch program, saving approximately $2,000 per patient that we keep at home instead of them going to the emergency department. That means we're also in a position to cut the cost of an intensive care bed by around 50%. An intensive care bed costs around $5,000 to $6,000 per bed day, and intensive care at home costs around $2,500 to $3,000 per bed day. And we're freeing up the most sought after bed in the hospital, which is the ICU bed. But most importantly, we're improving the quality of life for patients and their families, which is a win-win situation for all stakeholders. With intensive care at home, we are currently operating all around Australia in all major capital cities, as well as in all regional and rural areas. We are an NDIS approved service provider all around Australia, TAC and WorkSafe in Victoria, iCare in New South Wales, NIISQ in Queensland, as well as the Department of Veteran Affairs all around Australia. Our clients and we as a service provider have also received funding through public hospitals, private health funds, as well as departments of health. We are also the only service provider in Australia that has achieved third-party accreditation for intensive care at home nursing in 2025. We have been achieving this level of accreditation since 2012. No other provider has achieved this high level of accreditation in the community and has created more intellectual property for intensive care at home than we have. This puts us in a position to employ hundreds of years of critical care nursing experience combined in the community. No other service provider in 2025 employs a higher skill level in the community than we do, which enables us to look after the highest acuity adults and children in the community in Australia safely. And if you're at home already and you're watching this, or if you're stuck in an ICU like in today's case study, and you realize that you don't have the right level of support, I'll give you a very tangible and real-world example today. One of our first clients, when we first got started over 10 years ago in 2012, was a client who was at home initially on a ventilator with a tracheostomy, with a support worker model 24/7, of course. Support workers or disability support workers are dangerous, and it is negligent having support workers look after a client at home on a ventilator with a tracheostomy. That is like flying the airplane with a cabin crew instead of the pilot, because anyone on a ventilator with a tracheostomy is at very high risk of medical emergencies 24/7, or even at risk of dying if they don't have a team of critical care nurses looking after them 24/7. This is actually evidence-based and is documented in our mechanical home ventilation guidelines that you can find on our website at intensivecarehome.com. Think about it. In an intensive care unit in a hospital, you wouldn't have support workers looking after a critical care patient on a ventilator with a tracheostomy. So why would anyone in their right mind would do that in a home care environment in the community? So this client and the ICU that he was going back to found out about us eventually, and they engaged us, and we were proving our concept intensive care at home with this client very fast. When we worked with the client, we sent him intensive care nurses 24 hours a day, and he never ever went back into ICU ever again. And we were proving our concept there very fast. We can do the same for you if you're not safe at home, which includes the advocacy for funding that goes along with it. We have always successfully advocated for our clients. Otherwise, we would not be in business. The same is applicable for those stuck in ICU, similar to our case study here today. So what you're looking for is within reach, so please reach out to us. We are making it happen for you as well. We take you through the right steps, including NDIs or other funding bodies, and the advocacy that goes hand in hand around it. This is also why we are providing level 2 and level 3 NDI support coordination. We have a team of NDI support coordinators, and they have a wealth of knowledge. I've done an interview with Amanda Riches, one of our NDI support coordinators, and I'll put a link to an interview with Amanda in the written version of this blog. We're also providing TAC case management and WorkSafe case management in Victoria with Lucy McCotter. And if you're an NDI support coordinator or a case manager from another organization watching this, and you're looking for nursing care for your participants, please reach out to us as well. If you're looking for funding for nursing care for your participants and you don't know how to go about it and what evidence to provide, I encourage you to reach out to us as well. We will help you with the right level of funding, with the right level of advocacy. We're also providing NDI specialist nursing assessments done by critical care nurses with a legal nurse consulting background. And if you are a critical care nurse and you're looking for a career change and you want to join a very progressive, dynamic, and high-performing team of critical care nurses in the community, we are employing hundreds of years of critical care nursing experience combined. If you are looking for a career change, we're currently hiring for jobs for critical care nurses in Melbourne, Sydney, Brisbane, in Albury, Wodonga, in Bendigo, in Geelong, and in Warragul in Victoria. If you have worked in critical care nursing for a minimum of 2 years, in pediatric ICU, ED, and you have already completed a postgraduate critical care nursing qualification, we are delighted hearing from you. I have a disclaimer though, because we are offering a tailor-made solution for our clients, which includes regular staff, our clients also do want the same staff coming over and over again because they are very vulnerable and very special, and that's why we need regular staff. So if you're looking for agency work where you can come and go, this will not be the right fit for you. We are looking for consistency, and our clients are looking for consistency. So please only apply with us if you can give us regular and consistent availabilities for shifts, and you're really keen on building relationships with us and with our clients. And if you're an intensive care specialist or an ED specialist, we also want to hear from you. We're currently expanding our medical team as well. We can also help you eliminate your bed blocks in your ICU and in your ED for your long-term patients or for your regularly readmitting patients with our critical care nursing team at home. We're here to help you take the pressure off your ICU and ED beds. And in most cases, you won't even pay for it. Even if you do pay for it, it is much more cost-effective than what you're paying for in ICU and ED, and you get the same level of quick care. And if you're a hospital executive watching this and you have bed blocks in your ICU, ED, respiratory wards, home TPN, of course, please reach out to us as well. We can help you eliminate your bed blocks very fast. If you're in the US or in the UK and you're watching this and you need help, we want to hear from you as well. We can help you there privately with one-on-one consulting and hiring nurses privately. Once again, our website is intensivecareathome.com. Call us on one of the numbers on the top of our website or simply send us an email to info@intensivecareathome.com. And if you like my videos, subscribe to my YouTube channel for regular updates for families with intensive care at home and intensive care. Click the like button, click the notification bell, share this video with your friends and families, and comment below on what you want to see next, what questions and insights you have from this video. Thank you so much for watching. This is Patrick Hutzel from intensivecareathome.com, and I will talk to you in a few days. Take care for now.